He's the executive director. So, and if you are joining us on the conference call, please mute your line.
Using *6.
Disability healthcare policy.
Well,
Check
I
that.
just wanted to welcome everybody on behalf of Disability Rights Wisconsin.
Disability healthcare policy.
There we go. Good morning. And on behalf of Disability Rights Wisconsin, I want to welcome everyone here, the members of the National Council on Disabilities, Chair Jeff Rosen, who is not able to join us here present, and Camila Martin-Proctor, the co-chair, and all of you who are participating today, both in our beautiful Wisconsin Capitol building and on the phone. We are very pleased that the National Council on Disabilities chose to come to Wisconsin and to hold this hearing on this important issue of Medicaid managed care in people with disabilities. This is an issue that's very important here in Wisconsin and certainly across the nation, so we look forward to learning from all of you. I have the pleasure to invite all of you that are here present in Wisconsin's Capitol down to the second floor assembly parlor for a free lunch in the West Wing. So hopefully you'll remember that, the West Wing, on the second floor of our Capitol for lunch. Thank you again and welcome. I hope you have a great day and it will be tremendously informative. Thank you.
Let's try this again. Hi, good morning. On behalf of the President's National Council on Disability, I would like to welcome you today to our Wisconsin Medicaid Managed and Long-Term Care Forum. My name is Camila Martin-Proctor. I serve on the National Council on Disability. For our friends on the phone and on the web, your line will be placed on mute until the question and answer period. However, if for some reason you can no longer hear the conference, please alert us by calling 202-272-2004 or via email at Proctor, Proctor, .Camila, KAMILAH, @ncd.gov. During the question and answer period, we will unmute your lines at that point. If you are not the person speaking, please place your phone on mute using *6 to reduce the background noise and allow your fellow conference participants the opportunity to ask and receive a full and audible answer to their question. We thank you very much for this attention to this detail. As I said, once again, unless you are being asked a question at that point, please place your line on *6 to reduce the background noise for those on the phone and those of us here in person. We would also like to welcome our ASL interpreters and our CART reporter. Thank you so much for your service. The forum will have periodic breaks for our communication team to refresh. For our friends in the audience, if you need any of us to reposition ourselves for effective communication, please let me or Ellen know. We will be having a Q&A session after the presentation. At that time, you should either speak with Ellen or myself so that we can put you in a queue to line up for the appropriate microphone. However, due to the limited amount of time, we may not be able to get to all questions. If you write your question down with your name and email address on one of the index cards at the table, which will be handed out by Mr. Lawrence Jones, we will be happy to get back to you. Please follow the forum on Twitter with #MMCWI. We will also be broadcasting on cable channel 995, which can also be seen online at www.wiseye.org. The National Council on Disability was established in 1978. We are an independent federal agency currently composed of 15 members. Our office and professional staff are headquartered in Washington, D.C., and our work here could not be done without them. The overall purpose of our agency is to evaluate policies and programs ensuring equal opportunity to people with disabilities. This is an ambitious agenda that greatly exceeds NCD's size and modest resources. We review federal laws and programs, assessing the extent to which those laws and programs encourage the establishment of community-based services and contribute to the independence of people with disabilities. NCD fields thousands of telephone calls, emails, messages, and letters from concerned individuals and organizations. We disseminate disability-related information through our monthly NCD bulletin, which can be found at www.ncd.gov, our agency reports, and position papers. As you know, NCD has made it a priority to reach out to the community, and today we are here to discuss the new Medicaid managed and long-term care with you today. We would like to thank and welcome the Kansas legislature, the Wisconsin legislature. Forgive me, we are not in Kansas anymore today.
It's been a long few months,
It's been a long
folks.
few months.
We want to be in Kansas.
We are definitely grateful and happy to be here in this beautiful Capitol, in this beautiful building with all of you wonderful people. And we would like to welcome the legislature. If you would please stand and be recognized and let us know what committee you are serving on.
Hi there.
Thank you so much.
Representative Mike Rorcast, and I'm the Vice Chair of the Health Committee, and I was almost expecting Toto to walk, but it's become cross.
Thank you so much. Thank you so much. Thank you so much for being here. We would also like to thank Diane Cahaley and the U.S. Department of Health and Human Services for its participation and support of these community outreach sessions. We would like to thank, Ellen Pickle-Cafrich and her team for making all of this possible. We would have to thank the Disability Rights Organization and Chris Milatofrich and their organization, not only for sponsoring us, but for offering us this wonderful ability to be here. The Disability Rights Organization and Dan Idoskowski, thank you so much also for allowing us to be here. Now, it gives me great pleasure to turn this over to our amazing presenters and first moderator for the day, NCD Council Member and Chair of the Entitlements Committee, Mr. Ari Newman.
Good morning. Can you all hear me? Excellent. Yeah. Well, once again, thank you so much for having us here in Wisconsin. It's a pleasure to continue the Council's work with regards to the topic of Medicaid managed care and people with disabilities in your fine state. I'm going to begin the morning with a broad overview of some of the Council's recommendations with regards to Medicaid managed care. And to give you a sense of our orientation around these issues, the Council has been exploring the topic of Medicaid managed care and its potential impacts, both positive and negative, on people with disabilities since 2011, with our first policy outputs on this topic taking place in 2012 and 2013. We've conducted regional forums in obviously Kansas, but also Tallahassee, California, New York, Pennsylvania, and Baton Rouge, and a wide variety of other parts of the country. And really our goal here, and if we could just ask the folks on the phone to mute themselves, please. And our goal here is to really give a sense in a comprehensive way as to what Medicaid managed care is, and what are both the risks and potential benefits of Medicaid managed care as a payment delivery model for services delivered to people with disabilities. So I'll begin with slide 2 that just gives a little bit of background on who NCD is as a federal agency. We are an independent federal agency, which means that we have the power to issue recommendations on everything and make requirements on nothing. We serve as the federal government's think tank on disability policy. And while a number of our recommendations on Medicaid managed care have been adopted by the entity with primary regulatory authority over the Medicaid program, the Center for Medicare and Medicaid Services, I do want to be upfront as to our role, which is predominantly advisory on these issues. We have 9 members appointed by the President and Congress, and we advise Congress and the executive branch on the broad scope of disability policy, ranging from education to transportation to health care to long-term services and supports. We've chosen to make Medicaid managed care a high area of emphasis for the Council, in part because of the significant impact it can have on people with disabilities. And so out of the broad scope of disability policy, in the last several years, managed care has represented a disproportionate focus of our efforts. And I'm going to talk a little bit, and let's go to slide 3 now, as to why that is. So managed care is not a new concept by any stretch of the imagination, and folks here in Wisconsin should be very aware of that, given that discussions here have predominantly focused on moving from one existing model of managed care to a new model of managed care. Managed care can mean many different things in different states. Some states operate managed care frameworks in which the state serves as its own managed care organization. Some states operate managed care frameworks in which nonprofit organizations serve as managed care organizations, and some states operate managed care frameworks in which national insurance companies serve as managed care organizations. And in fact, many states operate hybrids of all of the above. The majority of Medicaid beneficiaries today have some component of their Medicaid benefit delivered through a managed care delivery framework. But if we look at the early history of managed care, we notice a couple of things that are a little bit different from how the conversation on Medicaid managed care is going nationally today. First, historically, managed care was utilized predominantly for acute care services, services delivered by a primary care physician or specialists that were very clearly medical in nature. And managed care was focused initially predominantly on non-disabled, low-income adults. And that really comes out of the fact that, the essential nature of a managed care relationship, or the most common managed care relationship, capitated payments, providing an average payment to a managed care organization that equals the anticipated average payment for serving the people within that managed care population it's much easier to calculate with the non-disabled adult population than it has been with regards to people with disabilities or people with various chronic illnesses or special health care needs. And again, because of that, the cost savings to be realized by managed care were really looked at as things that would materialize predominantly because of improved care coordination and various efforts at preventative care that would be materializing within the life of a 3 to 5 year managed care contract. Essentially, with the non-disabled low-income adult population, it's much easier to realize those cost savings predominantly through that prism of preventative care and improved care coordination. But increasingly over the last 10 years, we've started to see managed care shift to cover new populations, in part as a result of the pressure to cut state budgets, in part as a result of a recognition that care coordination does legitimately need to be improved in many parts of the country for long-term services and supports and people who experience disabilities or chronic health problems. And there are a couple of significant differences with regards to delivering managed care for people with disabilities or people with chronic health conditions as compared to the previous population. One is very straightforward. When talking about supporting people with disabilities, managed care organizations need expertise on long-term services and supports. And this is really a very different kind of service as compared to acute care. And there are often, as we're going to be discussing, a number of very real risks when an organization that is predominantly used to interfacing with doctors and hospitals suddenly faces the challenge of understanding how to interface with a long-term services and supports infrastructure, with home and community-based service providers, and understand concepts like self-direction, supported employment, supported living, person-centered planning, and so on and such forth. But one of the other characteristics that really materializes in the shift to managed long-term services and supports is that to a significant degree, even within fee-for-service Medicaid, managed long-term services and supports already experience a significant amount of care coordination. So the cost savings associated with Medicaid managed care aren't as likely to come out of just applying additional preventative care or care coordination. Instead, generally with managed long-term services and supports, cost savings materialize by the managed care organization achieving successes in moving away from legacy infrastructure. And in fact, some of the states that have had the most success with managed care have done so in part by utilizing the managed care contract as a framework for moving people out of nursing homes or out of institutions, or increasing the number of people with disabilities in integrated employment, and really requiring managed care organizations, on pain of financial penalty and with the offer of financial reward, to make progress in accomplishing these goals. And one of the other issues that materializes there, of course, is that often the infrastructure investment required to achieve success within the context of moving away from legacy infrastructure will not realize cost savings during the life of a typical 3 to 5 year managed care contract. Some of those returns will accrue to the residents of that state far beyond that 3 to 5 year contract. And so it becomes important to build into the managed care organizations incentives, whether that managed care organization is a for-profit, nonprofit, or state entity, a strong incentive to look beyond just the life of a particular contract and to realize those returns after a 3 to 5 year period. So if we can go to the next slide, I'm going to highlight 7 broad areas in which managed care and people with disabilities interact, and in which we believe states seeking to design a managed care system should take into account before moving forward with a contracting process, or really even an RFP. These are designed and really emerge out of our national, and if we could just ask the folks on the phone to mute themselves again, or if we could take the phone line off of speaker until we are ready for the Q&A, that would be great. Thank you. This is really designed to reflect our experience at the national level, rather than any particular circumstance specific to Wisconsin. And it really comes out of the need for...
Hi. Friends on the phone? Hi, can you hear me? Great. I need all of us to be good global citizens to each other. We have to ask that you mute your line using *6. Otherwise, nobody, not those of us in person and not those of you on the line, will be able to hear the presentation. Please mute your phone and or please take your phone off a speaker until we have our question and answer period. Thank you so much. I'm sorry. All right, please continue.
So we're going to highlight a couple of major areas in which states need to take into account. The first is community integration. And again, managed care organizations, managed care, if we can move to the next slide, managed care can be a tool to move people into the community. Given that generally speaking, home and community-based services are more cost-effective than institutional services, if a managed care organization has a capitated rate structure that incentivizes community living, that either pays the managed care organization the same amount for the same individual, whether that person is in the community or in an institution, or pays more for a community-based placement, then that managed care organization can have an incentive to move people out of nursing homes and out of intermediate care facilities and into home and community-based environments. One of the risks associated with managed care frameworks that are poorly designed is many states have carved out the institutional benefit within their managed care system. And what that's meant is that you have a dynamic in which, say, a state's home and community-based services for people with developmental disabilities are in managed care, but all are part of the state's intermediate care facilities are in fee-for-service. Or a state's home and community-based services for seniors are in managed care, but all are part of their nursing homes are in fee-for-service. And that creates a really problematic incentive for the MCO, because what it means is that the MCO then is motivated to shift into an institutional setting anybody whose costs are higher than their average capitated payment. For managed care to work as a tool for community integration and to avoid being an active obstacle to community integration, the institutional benefits for a particular population whose community benefits are being moved into managed care must also be moved into managed care. And really avoiding these institutional carve-outs is one of the Council's strongest recommendations on this topic. The question of how we define community integration is also very important. Many of you are aware that CMS has new requirements that every state will be required to meet by 2019 with regards to what is and what is not home and community-based services. These must be written into the managed care contract, and MCOs must be held accountable not only for shifting people out of the broad funding categories of SNF or ICF or IMD into HCBS, but in making progress on community integration within the HCBS waiver, such as moving people out of group homes and into supported living, or out of sheltered workshops and segregated day programs into integrated employment or integrated day activities. And again, as part and parcel of this, we need to avoid the medicalization of services, recognizing that you're often going to have a dynamic in which an MCO is coming in that may have limited prior experience with long-term services and supports, and ensure that crucial things like self-direction and person-centered planning are maintained. Provider network adequacy. Now, the typical model with regards to managed care is that an insurance company or another managed care organization contracts with a certain number of providers in order to deliver their services. And so all of a sudden you have a situation where providers need to learn a drastically new set of skills around negotiating with managed care organizations, particularly if there are multiple MCOs within their area, around arranging billing arrangements that may be different across multiple different MCOs. This can often place small and non-traditional providers at risk, and we know that in the home and community-based service system, non-traditional providers have historically been a source of disproportionate innovation. And so some states have adopted a variety of models to try and protect against this. Many states require MCOs coming to the area to contract with an existing scope of providers. Some states are requiring MCOs operating in an area to agree on a standardized billing infrastructure to save small providers the administrative costs of suddenly moving from one entity that they build to 3 or 4 or 5 with potentially different arrangements. There are a variety of efforts to provide technical assistance to providers and to MCOs with regards to increasing their MLTSS knowledge. But critically, states have to assess the degree to which a particular population's provider network is ready to move into managed care prior to making that shift. And if they're not ready, they need to be willing to delay that shift for that particular population, recognizing that different populations may be ready at different times, or may be a better or a worse fit for a particular managed care infrastructure. I want to highlight perhaps the most important topic in Medicaid managed care, which is the issue of accountability. We are contracting with external entities to manage a state's publicly funded programs. And so the obvious question that should emerge here is, how do we know whether or not they are doing a good job? And when we talk about acute care, there's a wide range of quality measures that have been developed here relating to, have people been in an emergency room in the last 12 months? Do people have diabetes? Do people, et cetera, et cetera? But when we're talking about long-term services and supports, the topic of quality measurement is still relatively new. And states need to build quality measures that they can write into the managed care contract and hold MCOs accountable to from a financial perspective that will relate to the needs of people with disabilities. One of the best practices models we've seen in the developmental disability sphere around this is the National Core Indicators Project. It's currently being adapted to the aging and physical disability space. There have also been a variety of efforts to utilize things like rates of integrated employment, rates of removal from nursing homes and shift into community-based services, rates of self-direction, which is one particular model that I'm fond of because not only does it ensure the preservation of self-direction, it creates a financial incentive for MCOs to actively recruit and educate people about self-direction as an option. Tennessee has adopted that in their aging and physical disability system. And other measures that, again, can be built into the managed care framework. We were in Kansas. One of the things we discovered is that Kansas is withholding about 5% of their payments to MCOs in order to evaluate whether or not they are meeting these outcome measures and rewarding those payments predominantly on the basis of those kind of quality considerations. I'm going to briefly highlight employment outcomes. I think folks in Wisconsin are very familiar with how important this is. Generally speaking, we want to make sure that managed care organizations recognize, and they may not, given that managed care is particularly new in the developmental disability space, that suddenly they will be in the business of paying for employment services, and that in fact Medicaid is a major payer here. Supported employment is one of those services that's cost effective over time, but the real ROI on it may only materialize after that 3 to 5 year period in the managed care contract. So it really has to be spelled out that the MCO will be held accountable for these kinds of things. And given all of the work that's been done previously, getting state DD agencies and other aspects of Medicaid to interact with voc rehab and the public school system, we want to ensure that there's a mechanism for managed care organizations to continue that interaction and continue to be held responsible for interfaces with non-Medicaid infrastructure. Finally, I'll add that we believe very strongly in making available data around employment in a publicly accessible way that disaggregates by region, that disaggregates by provider, and critically also disaggregates by managed care organization. Consumers should be able to see that people being served by managed care organization A have better outcomes in employment than people being served by managed care organization B. And that data should be made available not a year or two after the year in question, but in as much as possible in real time on a quarterly or a biannual basis. Managed care really includes, and employment is one example of this, a more diverse benefit package than acute care services. Family support services are another example in which the cost of not providing these things might not accrue in the life of a managed care contract, but there's a tremendous human and eventual financial cost here as well. Families will, and I think this is really to their credit, hold on for as long as possible before sending a relative into a residential service environment, whether that's an institution, a nursing home, or a group home. It's very important for us to recognize that A, we have a human obligation to support families, but B, there's a financial incentive because a family is going to be able to provide support in the home for much longer and keep somebody out of a much lower quality and much more expensive residential service provision environment if family support is provided. We want to make sure that if a family is going to be likely to give out around year 6, that a managed care organization doesn't have anything within its contract that would allow them to effectively say, that's outside of our contracted period, it's not our problem. State managerial capacity. This is an incredibly complicated system that requires strong oversight on the part of the state. We need to understand managed care not as privatization of Medicaid. If your state policymakers see it as privatizing Medicaid, then they are probably not going to be doing it effectively, but as contracting for a particular kind of service on the part of the managed care organization. And as with any contract, the entity that is doing the contracting needs to understand the work that is being done and have a clear knowledge about the population in question, a clear ability to track outcome measures, and a clear ability to monitor things like due process, grievance and appeals procedures, and other things that help retain the broader knowledge base on the populations being served and allow them to serve the managed care infrastructure in an effective way. We've often held up Wisconsin's ombudsman system as a model for other states to follow by virtue of the fact that you require a clear ratio of ombudsmen to beneficiaries. And that's something we often don't see in other states. In one state we went to, there was precisely 1.5 FTE for the entire state's Medicaid program devoted to ombudsman services. Generally speaking, as I'm sure heroic that 1.5 individuals were going to be, that's not an effective means of managing a managed care program. Next slide.
Yes, good afternoon. Our friends on the phone, thank you so much for joining us. If you could please place your line on mute using *6 and/or place your phone off of speaker, it would be greatly appreciated to reduce background noise so that everybody here in person and on the line can hear the forum. Thank you.
And again, different populations should be approached differently. Prior to moving not only the state as a whole, but a particular population within the state must conduct a readiness assessment and determine an appropriate phase-in schedule for managed care. And depending on the level of provider adequacy, competence with managed care, MCO competency with the particular population, and most importantly, the level of engagement that's happened with self-advocates and families on the part of the state and on the part of the MCO, whether or not a population should be phased in or when they should be phased in is very, very different. So I've highlighted a couple of basic questions here that relate to what your state should be thinking about on managed care. Many of these things are reflected within the council's documents on this topic and are available at ncd.gov in our healthcare section. In our healthcare section, we don't have that.
Oh, okay. I'm sorry. I thought we did.
In our healthcare section in 2012 and 2013 in particular. But we really want to highlight at a broad level stakeholder engagement, a clear accountability mechanism, both in terms of quality and questions like grievances and appeals, and a strong understanding as to what the model is for cost savings and quality improvement. Too many states have this idea that step A is managed care, and step C is massive cost savings and quality improvement, and somewhere step B has a question mark on it and they'll figure it out later. That doesn't work. And we really want to ensure that states do not adopt that kind of framework. I'm just going to very briefly highlight the new rule that CMS has just proposed on Medicaid managed care, because it's probably going to be relevant to what Wisconsin ends up doing in the future and really what happens in general. The rule establishes a number of important components that managed care organizations will be required to be held accountable to in the event that this rule is moved into final form. The first is it sets a minimum of an 85% medical loss ratio. That means that MCOs must spend at least 85% of the funds that flow into them on medical care for the people who are being served. This is very similar to the requirements the Affordable Care Act placed on private insurance. States can set a much higher medical loss ratio, and states can determine different rules as to what does and what does not count as a medical expense. This is quite important in part because states want to ensure that MCOs are spending their money on their beneficiaries, but they also don't want to disincentivize spending money on things that are not medical but may have an impact on medical outcomes. If an MCO is spending money on housing navigator services, for example, to help people find access to housing that's affordable and accessible to get them out of nursing homes, the state needs to very clearly articulate if that's going to count towards the medical loss ratio to avoid creating a disincentive for those kinds of social determinants. This rule requires clear appeals and grievance standards, clear readiness review standards. It creates a structure for engaging stakeholders regularly in monitoring and oversight with regards to managed long-term services and supports. And it articulates a plan for a quality rating system for managed care organizations that will be aligned with the broader rating system for private insurance. The rule articulates that managed long-term services and supports have to be consistent with the ADA and Olmstead, and particularly articulates, although it doesn't get into as much detail as we would like, that payment methodologies have to reflect goals to incentivize both better health and community integration. It states that enrollees have a right to a single point of contact on complaints and concerns and assistance with enrolling, disenrollment, and appeals. It requires that managed long-term services and supports have providers meet the person-centered planning requirements of the new settings rule. And I want to highlight in particular, it changes the definition of medical necessity and particularly highlights the idea that enrollees should have the opportunity to access the benefits of community living, and funds spent towards those ends will now meet, under this rule, the definition of medical necessity. And that's a very important innovation for the Medicaid system as a whole, because how medical necessity is defined is one of the most difficult things that often comes up in state negotiations around applying managed care frameworks. And then finally, the rule also sets some time and distance standards. It requires states to set time and distance standards for provider network adequacy. That means stating things like people should not have to travel more than X number of hours or Y number of distance in order to access a supported employment or a supported living or another kind of service provider. And it requires that enrollees be allowed to disenroll from managed care at any time, or if a state is not allowing disenrollment, that they be allowed to change managed care plans whenever terminating a provider from a managed care plan would result in a disruption to that person's residence or to their employment. I think we're coming up at the end of our time, but I want to see if we have the opportunity to take one or two questions from the audience. And I'll just say very briefly here, the Council's orientation to managed care is neither positive nor negative, but we believe that if you do it, you should do it right. Like splitting the atom, managed care can be used for great good or great evil, and you want to be very, very careful when you're doing it. Do we have any questions from the audience? Please come up to the microphone.
Can we get a copy of your outline?
We'll send all of that out.
Yes, I just wanted to let everybody know for any of the PowerPoints that are presented today that I will send them out to those of you that RSVP'd. I have your emails. If you did not and you're here and would like the PowerPoints, just write down your email or your business card. Give me your business card. I'll make sure you get the PowerPoints.
Do we have any other questions? Up there in the front. So medical underwriting was prohibited in private insurance within the context of the Affordable Care Act. So we've had a fairly significant development in that regard. In Medicaid managed care, because the state is the payer rather than an individual, then the state is just determining the costs associated with shifting a population into managed care. And in fact, we want the state to be paying the MCO more for populations that would cost more to serve. But after the Affordable Care Act, it's no longer possible for private insurers in the private non-Medicaid system to engage in medical underwriting. That's correct. And can we take one more question from the audience? And we'll take all the way in the back, if you don't mind, sir. You, yes.
Examples of states that have implemented managed this population. Examples of contracts that Wisconsin administrators should look at that have incorporated many of the principles that you described in your book.
So I'll just start by repeating the question. Do we have examples of states that have done this well? Well, first, in other states, we've referenced Wisconsin's aspects of Wisconsin's existing system. So certainly that's been relevant to the discussion, and I would encourage you to be able to adapt what is already working in your state to allow it to continue to work. I think there are a few different models that different states have adopted. We saw some promising contract language in Florida, and certainly we can share that with you. Arizona has a fairly good example as to how to approach the operation of a state MCO over a long period of time. We've also seen some very strong contract language in a number of other states, particularly around quality measures, some of which have been adopted particularly for the dual eligible demonstrations. Much of this is reflected within the council's reports, particularly in 2012.
Ari, that might also be a good question to ask the speaker from CMS.
And with that excellent segue, I'd like to hand things over to my esteemed colleague Clyde Terry and move to our next presentation. Thank you all for joining us.
Thank you, Ari.
Okay, is this on?
Yes.
Okay, I guess I can be heard, even though I can't hear me. Thank you, Ari, and indeed, thank you all for having MCD come and spend our time with you today. Our next presenter, we're doing a quick shift to the agenda, is Mr. Rocky Nichols, who's the president of the National Disability Rights Network, and I'm hoping he's on the phone.
He is.
He is standing by. Okay. Mr. Nichols has presented before us both in Kansas and in Louisiana and has some very interesting information about what it's like on the ground once a state has moved forward with a Medicaid managed care plan. So with that, Rocky, I'll turn it over to you.
Great, thank you. Can everyone hear me all right?
Yes. Yep.
Yeah. Great. My name is Rocky Nichols. I'm Executive Director of the Disability Rights Center of Kansas. We're the protection and advocacy system for Kansans with disabilities. The title of my presentation is Kansas Experiences, Postcards from the Bleeding Edge. And that's very purposeful because some look at Kansas and say that we're on the leading edge of managed care in this nation. Advocates and people with disabilities on the ground would tell you that we're on the bleeding edge of managed care, and I'll walk through some of our experiences in our state. I won't have time to get to all the slides, but kind of the overview is to give you concerns and issues experienced in Kansas under what's called CanCare. That's what Kansas calls its managed care arrangement, which is basically taking all of Medicaid and putting it into a managed care arrangement with three for-profit, out-of-state, publicly traded corporations. Two, there's also some information on the national disability perspectives on Medicaid managed care, which we may not have time to get to today. And then three, I do highlight NCD's recommendation for a Medicaid advocacy program as well. So I'll just start there. We're very appreciative that the National Council on Disability has recommended that there be this Medicaid advocacy program, an independent ombudsman program, if you will, to ensure that protection advocacy agencies have specific funding from CMS to deal with all the different appeals and other issues that come up with managed care. Now, one of the great things about Wisconsin, as you know, is Wisconsin is a national leader in this area. So I feel like I'm kind of preaching to the choir on this one. Wisconsin had the foresight to actually set up an independent ombudsman program, and you provide funding to your protection advocacy system specifically to address these issues. So advocates across the nation, particularly disability advocates, look at Wisconsin as a model approach. And frankly, we wish in Kansas that we would follow the Wisconsin model, and we think it's very important. You guys have been a leader in this field, and it's been helping people with disabilities. And obviously NCD's recommendation backs that up as well. So next slide. The Kansas experiences. First, I want to kind of put a caveat on all of this. We are the protection advocacy system. And so we will hear about the problems. We definitely have our finger on the pulse of managed care in Kansas and how it impacts people with disabilities. But people don't usually call the protection advocacy system to report what a great job the system is doing. People call us when the system breaks down. And what I can tell you is that the system breaks down a lot more since the state has gone all in on Medicaid managed care than it used to. So we've seen, number one, large service reductions for some CanCare members, and I'll walk through all these in more detail. Two, huge reductions in the waiver capacity for home and community-based service waivers and overall enrollment in those waivers. Three, a lack of understanding about the EPSDT program by managed care organizations. That's the early periodic screening, diagnosis, and treatment program, which is essentially the most powerful mandated part of the federal Medicaid law that says for children and youth 21 and under, basically anything they need, they get, regardless of whether or not it's in your state plan. And there's a real problem with, under managed care organizations recognizing that program. Four, still are seeing improper notices of action. We're seeing not just plans of care being cut and reductions in services or denials of services or equipment. We're not seeing the state follow through on notices of action the way they're supposed to, according to the terms and conditions in federal law. 5, just overall concerns with the way the state has managed the HCBS waiting lists since they've gone to managed care. And then 6, people just getting lost in the system. That includes the end of case management as we know it, and I'll walk through what that means in our state. And as one advocate and a person with a disability described it to me, is that the system really seems set up to fail people. And they described it as death by a million bureaucratic paper cuts. There just seems to be more and more red tape and bureaucracy and more difficulties to get access to health care. So those are kind of the 6 main points I'm going to make. Starting with number 1, the large reductions in services for some members. It's not uncommon for our agency to see reductions in plans of care, upwards of 50% decreases. We're talking from going from 70 to 100 hours to 30 to 50 hours a week. And obviously when you're talking about plans of care for people who have complex in-home medical and long-term care needs, you're talking about people's independence. You're talking about whether or not they're going to be able to fully function as a citizen in our society. Just give you one example. A client we had significant seizure issues, and prior to managed care, they were getting 24/7 care, that's around-the-clock care because of their seizure issues. The managed care company reduced the plan of care and approved support for only 16 out of the 24 hours, even though they didn't have any other natural or other proper supports in the home. And that was and still is a real problem for that individual because their seizures haven't gotten better, their disability hasn't improved, and yet, they've experienced a significant reduction in the number of service hours they have. Another example, a client we had who was incontinent, and she also was at a serious risk of falling. She was actually asked by the managed care company to go without services. And these are services that her doctor says that she needs to prevent future falls. And her doctor says that if she doesn't receive these services, then there's going to be a real problem because she's going to be more likely to have falls, and literally her life is at risk because if she has another fall, her doctor thinks that there's a chance that it could complicate her to where she will be totally disabled for the rest of her life, or may end up causing her serious harm or even death. Another client we had was a person with a significant mobility impairment issues, hip issues, other mobility issues. She requested an increase in hours after leaving a nursing facility. Different case, but it was again to prevent falls. And so that request was denied. So think about that. She was in a nursing facility, wanted to get out. That was obviously getting out is better for her, better for taxpayers, and it saved taxpayers dollars by having her leave the nursing facility. Her doctor actually wrote a letter and said that she had to have more hours because with this example, one more fall, that she would have permanent, irreparable hip damage. And so before she went into the nursing facility, she had one set of hours. She goes to the nursing facility, she gets transferred out, and the managed care company actually reduced her hours even further. So think about that. Her hours were reduced from before she was in the nursing facility. And quite frankly, she doesn't have the proper supports. And she was forced into an expensive hospitalization. And, when that happens, that's not good for anyone. It's not good for community-based needs-based services. It's not good for the person with the disability, and it's not good for the taxpayers because institutional facilities cost a whole lot more. But
3 minutes,
sometimes,
Rocky.
what's that?
3 minutes, Rocky.
Okay. Sometimes that's a real issue. Huge reductions in waiver capacities. I'll skip over that because I know you guys don't have that as an issue in your state. I'll skip down to number 3, lack of understanding about EPSDT. That's the Early Periodic Screening, Diagnosis, and Treatment Program. It's one of the few entitlements in Medicaid. It's a mandated coverage. Basically, kids under 21, they're supposed to get everything. Whatever the doctor says, even if it's not covered by the state Medicaid plan. Quite simply, there are different rules for kids under 21. Next slide. More and more, we're seeing managed care organizations denying services, denying supports, and denying durable medical equipment in violation of the EPSDT program. They're using adult criteria when, again, children under 21 have different rules. They're improperly denying attendant care because they're saying it's, quote, not a medical service. And EPSDT, they're saying, is limited to medical services. That's not true. The federal law and the special terms and conditions are very clear on this. They're saying attendant care is optional. Well, it's not optional. Just because it's not covered by the state plan, it still has to be covered. So in Kansas, I really feel like I'm a cheerleader because I'm always talking about give me a T. And what I mean by that is EPSDT stands for Early Periodic Screening, Diagnosis, and Treatment. Well, in Kansas, since managed care, the focus has been on the E, the P, the S, and the D, but they're not doing the the T effectively. And the T is treatment. That's when the rubber hits the road. That's what actually helps kids, prevents them from going in institutions. And so you can look at the training manuals by MCOs. They focus on everything but treatment. Why? Treatment costs the most. But it also could do the most good. The state Medicaid agency, Kansas Department of Health and Environment, their own website portal, when you go to facts about Medicaid and CAN-care eligibility, it doesn't even mention EPSDT or these benefits. And EPSDT is unfortunately a well-kept secret. Finally, just to wrap up, continued problem with improper notices of action. That means when someone's services get cut or reduced, they're not providing true, effective, informed consent as to what their rights are to appeal. Now, the good news there is that the state of Kansas did listen, and they worked closely with stakeholders to develop a new standardized notice of action form. And before this new form, every CAN-care member was, and CAN-care is, again, is our managed care organization, they were misinformed about their appeals rights. It was a good form, great format. The problem is this excellent new form is still not being used consistently in our state. We still see managed care companies using the old form, and at this point we have to call it out as being something that's either purposeful in the system because every service you deny, every month you delay is going to save you money. Because if you're talking about long-term care, you're typically talking about care for the rest of the person's life. And so if you're able to delay that 3 months or 6 months or 9 months, that's more of a, for the bottom line profit margin. And just finally, the overall issue is, people getting lost in the system. When advocates testified on Medicaid managed care, one of the things we talked about is that Kansas was gambling with the lives of people with disabilities because they were going all in on managed care. And that's literally what Kansas did. They pushed all their chips in and said, we're going basically entirely to a managed care arrangement for almost all of Medicaid. And that was a gamble, and we think that it's hurting people with disabilities and hurting Kansans in our state. I'd be happy to stand for any questions.
Thank you, Rocky. I think we're going to hold questions until after Diana Nyad from CMS speaks, and then between the two of you, I think we should have a good dialogue. So I'm going to check to see, is Diane on the phone?
Yes, I'm here.
Terrific. Okay, Rocky, if you can stand by, and Diane, I'd like to introduce you. Just to give you a scene, I guess we have about 100 people in the room, some state legislatures here in Wisconsin, a number of advocates, lots of folks with disabilities, and folks, this is Diana Nihad, who is the... Kelly, I'm sorry, I apologize, Kayla, who is sort of the Director of Aging and Disability Services for Centers for Medicaid and Medicare. And so, Diane, I'd like to turn it over to you for your remarks.
Okay, thank you. Actually, just as a correction, I'm the Deputy Director of the Division of Managed Care Plans with the Disabled and Elderly Health Program Group. I don't want to give myself a promotion here, but what I'd like to just talk briefly with, can everybody hear me okay in the room?
Yes, we can.
Okay, great. What I thought I'd talk about, and I'll try to keep my remarks brief because I know people probably have questions for Rocky and myself, is a little bit about a recent notice of proposed rulemaking that was issued by the Centers for Medicare and Medicaid Services. We received over 7,000 comments, which we're very happy with, although, as you may imagine, we're still trying to get through all of them and make sure that we respond to all of them. But what we had done in this proposed rulemaking is set out a number of new managed care regulations for Medicaid. And a good portion of these regulation changes have come in the area of managed long-term services and supports. So many of the kinds of things I know Rocky and I heard Ari earlier speaking about are the things that we've tried to accommodate in this regulation and also through the different comments that people have submitted. So what we did is we defined a number of areas. We went back to guidance that CMS, we had issued back in 2013 that included 10 basic principles that we feel is very important for any state that's putting in a managed long-term services and supports program. These, as you all know, and we certainly know, these services are definitely not medical in nature, and they often focus on functionally supporting individuals in the community, and also, of course, for Medicaid, we also cover institutional services. However, we very strongly support, of course, the Americans with Disabilities Act and Olmstead decision, and any kinds of work that's being done to help ensure that individuals are able to be in the community whenever possible. So some of these, I'm going to skip over some of the elements. We certainly have more, and I'll be happy to share the section of slides that can be sent around afterwards. But some of the key things I wanted to touch on, one would be stakeholder engagement. And one of the new requirements we're proposing is that states have to have a managed care stakeholder group that solicits feedback from beneficiaries, providers, and other stakeholders. This would be in addition. Every managed care entity is already required to have an advisory group. So this would be in addition to it, and it would be at the state level rather than at the plan level, so that the state is sure to hear feedback on a broad level from what's going on in the state regarding managed care. We haven't prescribed the composition of the stakeholder group. We did have many, many comments on this. The reason being that the proper stakeholder group in Wisconsin isn't necessarily going to be the same as the proper stakeholder group, say, in Maine or, perhaps in an extremely rural state like Montana or Wyoming. However, the composition must be, it must ensure meaningful stakeholder engagement. So when we look at a state's submission and what they propose to do for their stakeholder group, what we look at as well would be looking at that particular state Are there tribes in that state? Are there particular ethnic groups? Are there, certain stakeholders that are missing from their stakeholder engagement? Also, are the states making it available to people and accessible to people to participate? Certainly, very few states are in a position where they can have everybody come in person, but are they enabling teleconferencing and things of that sort so that everybody has the opportunity to participate? Are they making materials available in alternative formats? So those are the kinds of things we look for on that. One of the other key areas is to make sure that there are enhanced provision of home and community-based services. In this, we directly refer to the ADA, the Americans with Disabilities Act, and we also refer directly to the Home and Community-Based Settings Regulation that was published in March of 2014. Both of these things are required to be complied with by the states. Just as a sidebar here, CMS mostly works with the states. The states are the ones responsible for overseeing the contracts with the managed care plans. So our requirements are on what the states must do, and the states, at the end of the day, will be required to submit to us annual reports at minimum. For some of the different managed care authorities, they may be submitting more frequent reports, but annual at minimum, and that will include things like how many people are receiving home and community-based LTSS versus those who are in institutional care, to make sure that there isn't a backward trend going on those sorts of things. The alignment of payment structures and goals is an element that we look for as well. Many states will say that there'll be, if their managed care plans include both institutional and home and community-based services, they'll have a single rate cell for both institutional and home and community-based services. What this means is, for most people, where home and community-based services are going to be less expensive than institutional care, it gives the managed care plans an incentive to help support people in the community versus, easily just pushing people towards institutional care. There are certainly exceptions to this. There are certainly a number of people who can very well remain in the community and live very independently, but may require very expensive supports to do so. And in those cases, we look to the states to say how they're going to assure that people who can appropriately be in the community are supported to do so. Sometimes what that means is we'll have a specific rate cell that's kind of like for those individuals who may be more expensive than institutional care, to make sure that their needs are accommodated as well without necessarily meaning they go into an institution. Another element of this is beneficiary support systems. This has been put into the regulation. This is an independent entity to provide support to beneficiaries that's independent of the managed care plans, because this is the entity that also provides enrollment counseling and things of that sort. We have to make sure that this is an entity that does not have any financial gain to be had by referring to a specific managed care entity over another, and that this entity is going to be looking and helping the individual to best meet their own needs, and not to be looking, necessarily just to fill slots in a given managed care plan. This is also the access point for complaints or concerns about enrollment, access to services, related matters. The beneficiary support system has to collect and submit to CMS data regarding what kinds of complaints are coming in, what kinds of assistance are being provided, and to look for, in the long run, looking for other trends that are showing that some more work needs to be done in a particular area. Again, all of these things are very dependent on stakeholder feedback that people who are in these plans are feeling that there are independent places they can go to report if there are issues, if they feel that they're losing services inappropriately. Medicaid always requires that there be a process in place for appeals. If that's not happening, then those are the kinds of things that CMS would want to definitely be hearing about directly through letters or through entities such as the stakeholder support system. I know we have a limited time here. I did want to add that we have incorporated a reference to person-centered planning for purposes of long-term services and supports. Person-centered planning, as many of you may know, is certainly a very intense process in which the individual or the beneficiary is the individual in charge of that service planning to help identify what their goals and needs are. That it isn't that people get everything they want necessarily, but that people get everything they need and that they get to choose how that's delivered to the extent possible within the Medicaid regulations and so forth. So in other words, there shouldn't be somebody sitting in an office somewhere saying, oh, this is what so-and-so needs because they have some certain diagnosis. That's, totally against what these regulations will provide for, and that each individual has the right to have in-person, person-centered planning, and that individuals receiving services are the ones who identify who should be part of that planning team. The one thing that is added to that is that it does include the providers of services for the individual. So if the individual is saying, for instance, that they would like to hire a family member to provide services, then that family member certainly has to acknowledge that they, in fact, are willing to be a service provider and what the role of that is. And that would be true of any service provider who's identified within that service plan for the individual. Certainly a comprehensive integrated service package. I know in Wisconsin, largely, your long-term services and supports are sometimes separated. I know with family care, there's more integration there. But, certainly we encourage where there are integrated services that the long-term services and supports aren't in isolation, but that the person-centered planning mechanisms for long-term services also are applied in helping the individual identify their preferable means of treatment for their medical issues as well. By this, obviously, there are certain things that a medical professional has to identify and has to be certified to provide. But there are also many things that a person who's lived their life with a disability knows about their treatment that may not be apparent to every primary care physician or not even most of them. So certainly availability of specialists and so forth would be very important to people, especially to people who have specific disabilities where a specialist would be the only one with a competency to provide ongoing care. Some of the participant protections include, as with many of the other long-term care things that are done through CMS, include reporting on and collecting any kind of critical incidents that are occurring and how they're being remediated and taken care of, making sure that individuals who are facing critical incidents have them addressed on a very, in an overnight, we have an hour time frame actually put onto that for things that are critical incidents, and that anything that affects the quality outcomes identified in the person-centered plan would be considered a critical incident and has to be worked on within 48 hours. That's the basic outline of what I hope to cover today. I don't know if I'll turn that back over to Claude, who perhaps we could take questions.
Sure. Thank you very much. I know I have at least one council member that has a question. I think I probably would then ask Rocky if he had a question for you, and then after that, open it up to the audience here for questions. So I believe member. Mr. Blumenthal, you have a question?
Yeah, hi, Diana. Diane, thank you for joining us again. In the comments made by Ari Neiman at the beginning, one of the comments he articulated was that with regards to the inclusion of long-term supports and services in managed care, that success generally comes when state Medicaid managed care plans include provisions that move away from legacy programs such as nursing homes and institutions. Is CMS moving towards a position where CMS will not approve managed care contracts unless those legacy programs are included with regards to LTSS?
This question is for me, for Diane.
Yes.
We don't really have statutory authority to require a state to include home and community-based services and institutional care within the same plans. That's something that the state has discretion of with Social Security Act statutory authority. However, every state we work with, we very, very strongly encourage and, it's to their own benefit as well as to the plan's own benefit to have those things within the same plan because it gives that built-in incentive to help individuals remain in the community. So far, I only know of one state that's actually in development phase that is in fact thinking of keeping them separate, but they're coming up with another solution to make sure that, and they're only keeping the rates separate. They're keeping them both within the plan, but keeping rates separate. But they're keeping an incentive built into it so that the plans will be penalized heavily if they show an increase in institutional rates.
Okay, I think
So it's not statutory, it's not required, but every program we know of right now in development is in fact, keeping them both together.
Thank you, Diane. I think Ari has a question, then we'll go to Rocky.
First, thank you very much for taking the time to join us. My question is something of a follow-up to Gary's, and it relates to the components of the proposed rule which reference in broad terms the ADA and Olmstead. And the reason I bring that up is that historically, in the past, when Olmstead issues have come up in states, CMS's position has been, at least as we understood it, that they feel that Olmstead enforcement and ADA enforcement is really the exclusive province of the Justice Department, and we've had, I would say, a number of significant concerns that Olmstead issues have not been adequately stressed as a requirement with respect to state approvals, CMS approvals of state managed care proposals. My question is, in light of the now explicit reference to the ADA and Olmstead within the proposed rule, can we anticipate a more expansive role for CMS in requiring states to meet their ADA and Olmstead requirements within their proposed managed care frameworks? And what will that role look like?
Thanks for the question, Ari. And again, I'm getting a very bureaucratic answer, but I'll qualify it as well. We do not have any statutory authority to oversee the ADA. By putting it as referenced in our regulation, we're making it clear that the states, and by reference the managed care entities, are required, as are really everybody, to comply with the ADA. That being said, the Department of Justice is part of our federal review team. They review everything before it's approved. So they certainly have that capacity to look at things before they're approved. and we would rely on them to be doing that scan to make sure that things, at least what we were seeing, was ADA compliant. Another thing that we do and have done for, I've been with CMS about 3 years, so since I've been there anyway, and I'm not sure how long before that, is we meet on a monthly basis with the Department of Justice, and we discuss individually issues in individual states. And we have on a number of occasions referred, particular states to the Department of Justice and asking them to do an investigation because we've heard complaints that they may not be. So again, I'm sorry that, we can't take on the responsibility of jurisdiction of the ADA because we just don't have that statutory authority. However, we certainly do pay attention and refer on to the Department of Justice when things come to our attention that appear to be some kind of an issue.
I'm not sure, Rocky, I was putting you on a spot. I wasn't sure if you didn't have a question for Diane.
You were cutting out. What did you?
I wasn't sure whether you had a question for Diane before we went to the audience here.
No, I didn't have a follow-up question.
Okay, thank you.
Can you guys take a phone question?
If you'd hold for just a minute. Let's see. We had a question from one of the members of the General Court here in Wisconsin. I'm not sure if you didn't want to ask your question again.
The gentleman over there with the CMS question.
And use the mic. Use the mic, please. Because Diane won't be able to hear you.
So my question was whether CMS has reviewed some of the contracts that states have made with managed care organizations and has recommended some in particular that Wisconsin administrators might want to look at that would provide some of the safeguards that have been discussed earlier in this presentation.
I didn't hear the entire question. Was it asking how we review?
Do you want me to rephrase?
Yep.
Hi, Diane.
How we review contracts?
Hi, Diane. The question is, have you had an opportunity to look at contracts from other states that would demonstrate sort of best practices that folks here in Wisconsin should take a look at? Is that a good summary?
I would have to say I have looked at contracts from a number of states. I don't believe as of yet we've seen anything that we would want to point out as a best practice. I'm not saying that it doesn't exist. I'm just saying that I don't feel I've had enough of any of these personally. What happens is the contracts are approved by the regional offices. So each regional office sees a subset of them, and then they'll send them on, and we'll take a look at some of the ones if they have questions or issues on. So I don't review all of them. I only review ones where there apparently is a problem, so I'm just not in a position to do that. I think it makes a lot of sense to be looking at that, and certainly as guidance in the future. But at this point in time, I don't think we'd be able to identify specific states as a best practice with their contract.
Are there any other questions from our audience before we go to the phone?
Yes, this is TK Swall in New York City. I have a question about CMS's oversight of managed care plans in terms of the recent Court of Appeals decision with respect to overtime payments. I work in the field of consumer directed care, and I'm concerned about the public authorization of hours and possible caps on services in the community as a result of this healthcare risk decision, which will implement the new overtime rules. And I'm wondering whether CMS can be really strong in telling managed care plans that simply budgetary reasons are not an adequate reason for not authorizing care.
I believe the question was about whether or how we oversee plans to make sure that they're paying overtime where necessary, or whether plans are authorizing sufficient care for individuals. Was that the question?
More or less, yes.
Okay. We really don't look at it that detailed. If the plan is cutting hours for individuals, I'll look at that one first. Then an individual should be afforded the opportunity to go to a state fair hearing and contest the reduction and show reason why that reduction is not appropriate. If a plan is just not authorizing or just not making available enough services for the individual, that's a different story, and that comes into a network adequacy issue, and that is definitely something that is reported to us on an annual basis. It's reported to us by the state, but they are supposed to be collecting that information from the individual plans. From a practical standpoint, if you as an individual are finding that you're not getting the services authorized in your plan of care, then what I would highly recommend is that you contact, if you don't have an independent consumer support entity in your state, an ombudsman or something of that sort, I would recommend that you could contact maybe your protection and advocacy systems, or that you look to whatever entity is set up in your state to address access to care issues. And certainly that would be important to report that back to the state. The plans are required to provide sufficient network adequacy for the populations that they've agreed to serve in their contract, and that's across the board. That's a requirement for all plans. And if there's an issue where they're not able to do that, then they have to have a plan, a corrective action plan with the state on how they're going to bring up their network adequacy. In some cases, we provide technical assistance to the states and by reference to the plans. And in that instance, some of the things we would highly recommend is certainly allowing payment to family and friend caregivers and self-direction kind of programs, to look at are there ways to use individuals' natural community supports as paid caregivers in order to ensure that individuals are getting the services they need. That would certainly be one of the recommendations if there just aren't agencies or other types of providers available in that neighborhood. We look at this, we only see the reports once a year. At the end of the day, one of the key components is that the state is supposed to be monitoring the plan access, and that if there are issues, then they should be putting corrective action plans in place to make sure that they're addressed.
Lisa, we have another question, Diana. Lisa?
Can you take a phone?
Hi, this is Lisa.
Hold on just a minute on the phone. Lisa.
Hello, this is Lisa Pugh. I'm with our State's Protection and Advocacy Organization, Disability Rights Wisconsin. Thank you so much to NCD members for being here today. My question is with regard to stakeholder engagement you talked about. I'm wondering if you've seen best practices in terms of the role a protection and advocacy agency can play in terms of stakeholder engagement, as well as our partners with the Developmental Disabilities Councils and the University Centers for Excellence in Developmental Disabilities. How are those entities engaged as stakeholders in states, and what would you hope to see in terms of their roles as stakeholders?
Well, they certainly, in any state where the individuals with intellectual and developmental disabilities are receiving long-term services and supports through managed care, I would certainly think all three of those entities would be pretty critical partners. you know, we can't really dictate who is involved in the state, but if those entities aren't involved and the people with IDD are being served by those programs, then I certainly think that would warrant a complaint to the state in terms of expanding the stakeholder engagement of that particular state.
Okay, I think we have we're out of time, but one more question on the phone.
And I got a question about if you get a job and you have to pay more for your benefits, and then it doesn't seem like you got anywhere. Is there a way to get around that?
You're saying if you get a job and you have to pay more for your benefits?
And if it seems like because of that if it seems like you also off, is there any way to get around that?
Oh, in terms of your eligibility?
Yeah, like if you have to pay a certain
I'm
amount.
sorry, I'm at a conference and they're changing sessions. It's very noisy.
Because you got a job, and if it seems like you also off because of that than what you were before you got a job, is there any way to get around that?
Yeah,
In terms
this is
of
Rocky.
income.
I would
Oh,
call
go
your
ahead, Rocky.
benefits. I would call your benefits planning office in your state. There are several different incentives through Social Security, state Medicaid buy-in programs, and other ways to where you can get a job and keep your benefits.
Okay,
So talk to
not
a benefits
only
planning
the
specialist.
benefits of not having to pay a lot more, you know.
Okay. All right. I want to thank our panelists, Rocky and Diane, for their time this morning. If you do have questions here in the audience that we didn't get to, there are cards that you can fill out and we can respond over the internet. And those on the phone, I think you can also send your questions to ncd.gov and we can answer them that way. So again, I want to thank Diane and Rocky for taking the time this morning. At this point, we're going to make a shift. I believe we have another panel to talk about
Yes.
best practices.
Yeah, we have Sue Urban, Drew Smith, and Donna McDowell. If you just come up here, we're going to use these spots up here at the dais. I think we're... Maybe Camilla, remind them on the phone.
Yes, good afternoon, my friends on the phone. Thank you so much for being with us. If you could please place your phones on mute using *6 as we begin our next panel. Thank you.
You are now muted.
Good morning.
Okay. Good morning, everyone. I guess we're all here, and I believe that voice sounds familiar. We'll start with Lisa. If you care to introduce yourself and where you're from. Well, they're all telling me that. I guess
okay.
it's
Do you want me to start?
Sure, go right ahead.
Okay, good day. Can you guys hear me? Can you hear me now? Okay. Good day. I want to thank you for the opportunity to speak today. My name is Sue Urban, and I'm the Director of Clinical Services for TMG. TMG is a Wisconsin-based company, and for more than 30 years has been an industry leader in self-direction, quality management, and service design. TMG serves individuals and communities throughout Wisconsin. I have been involved in long-term care for the past 36 years, first as a social worker, then as a nurse. I specialize in the care of individuals with intellectual and developmental disabilities, and I'm also a dementia practitioner. Sorry. For 36 years, I have fought to keep individuals out of institutions like nursing homes and keep people in the home and community they choose to live in. Managed integrated care is not just about medical care. It is holistic and person-centered care that addresses every aspect of a person's life. manage integrated care models that use person-centered strategies, hold the promise of better care coordination, better health and community integration outcomes for people with long-term care needs, which in turn reduce reliance on more costly supports and decrease costly and unnecessary hospitalizations. I would like to share with you a few stories in hopes that it will help illustrate what needs to happen on the front lines to ensure success. I want to tell you about John. John was in his late 20s when I first met him, and I was hired to be his nurse care manager. My task was to reduce his health care costs, which exceeded $250,000 a year. I was to reduce his hospitalizations, train his staff on medically delegated tasks, and most importantly, get him well enough so he could participate in life. John is a man with cerebral palsy and very complex medical needs. When I met him, he had been hospitalized an average of 15 times a year, with stays ranging from a few days up to a month at a time. He spent most of his time in bed in a darkened room. He was depressed and he was tired of being sick.
Hello?
He voiced his fears of being sick and his desires to be better to
Call
me.
or what?
Yeah, I'm listening from Milwaukee and I can't hear the tape.
Yeah, I can't hear anything either.
Yeah.
Okay. I hung up and dialed in again.
Hi, I'm so sorry. We're having a
And we
few
just
technical
totally
difficulties,
lost
but we are working on that at
policy
this
panel
moment.
discussion.
They can't hear us.
Was it
Okay,
good?
I'll send them a text message.
Thank you.
They muted us.
We can have our own policy discussion.
Pardon?
We can have our own policy discussion.
Yeah, I heard the policy panel, but now this 10:50.
No, I'm saying we can have our own discussion.
Yeah.
Forget about that.
Oh, we can hear you.
Oh.
And was it
That's
good
the
so
problem.
far? I just called in.
Can we mute them? Okay.
Was it good so far?
Yes, I'll try to talk over them. So anyway, John had a myriad of conditions which led him to having a feeding tube, a catheter, colostomy. He had rods in his spine. He had a mixed seizure disorder with a shunt, severe migraines. He used a CPAP with oxygen at night,
Doesn't work, stuff like that.
and he used a wheelchair
And
for
hi, this is
mobility.
Beth for Bliss
In
PMI
addition, he
too.
had
Do you
significant
know if they're aware that we're no longer getting
behavioral health needs.
Send them a text.
John was on over 30 medications a day.
Someone is sending them a text.
You can
Okay, thank you.
You can imagine the issues related to the use of that many medications.
Eric Miller is in the audience today, so I also just sent him a quick email hoping he'll get it on one of his devices to let them know, so I'm hoping they will connect back with us shortly.
Excellent. Very much.
I let Ben Barrett know also, he's in the audience. Rick Jensen,
Okay,
last three.
we can go on. He had 30 medications a day, and you can imagine the issues related to the use of that many medications. He had numerous medical providers, among which were a gastroenterologist, neurologist, rehab physician, urologist, psychiatrist, PT, OT, as well as a very devoted primary care physician. John also had other people helping him. He had a social worker, a live-in caregiver, and a few other caregivers that rotated shifts caring for him. He also had a job coach, but unfortunately was rarely well enough to work. Through attending all of his medical appointments, keeping each provider informed of what the other provider was doing, developing strict and consistent protocols for his home caregivers to follow, as well as developing and providing training on delegated medical tasks, we were able to reduce ER visits and inpatient stays. Because of these protocols and training, John started to feel better physically and mentally.
Can you hear me?
Hear you.
Yes, I am so terribly sorry. At this moment, we are having a few technical difficulties, but we will be having you rejoin the conversation very soon.
If you could still please place your lines on mute at this time. We are working to unmute the lines that you'll be able to hear us. I'm terribly sorry. Okay, thank you.
Thank you very much.
Sir, we're having a few technical difficulties at this time. I do realize that at this point you cannot hear the conference. We are working to make that correction. You should hopefully be back online in the next 5 minutes. If you could please mute your line at this time, I'd greatly appreciate it. Thank you.
Thank you.
We'll keep trying. It's challenging. Okay, because of these protocols and trainings, John started to feel physically and mentally better. As his cares were being consistently provided, staff now knew how to support his complex medical and behavioral health needs. With a well-trained, stable, and reassuring staff, in the course of 2 years, we were able to reduce his readmissions from 15 a year to 1 in 14 months. We were able to cut his medications in half, from 30 to 15 medications, and most importantly, get him engaged in community activities and events, and get him to work, and keep him employed. That is what it takes. While I no longer work with John, and it has been 10 years, he has remained stable and employed through the efforts of his team, and he has a life. Next, I'm going to tell you about Mary. She was a 21-year-old woman when I met her. She has a diagnosis of Down syndrome. She had just graduated high school, and the part-time job she had ended. She lived in a rural community, and she was home all day. When she wanted a job, and whenever she saw me, she said that she was still not working. She told me she was bored, and she told me she was sad. I saw her every few months and was frustrated as she was that she had no meaningful work or anything in her day. Over time, she became depressed. Now she had a diagnosis of depression and medication to go along with it. She had her mom, she had a personal care worker, and she had me, her nurse. But she needed a life. She had hired a new support broker, and we all banded together. We worked as a care team, and in 4 short months, we were able to get her not 1, not 2, but 3 part-time jobs. She also joined a community exercise class and began classes at the local community college. Within 6 months, she was off her antidepressants and has been working and engaged in her community since. More importantly, she has a life, her life. These stories illustrate some important lessons. If managed integrated care models are to succeed, these models should include commitment to training both clinical and non-clinical staff on person-centered planning and the use of person-centered strategies, asset-based mapping to identify community and individual resources, non-traditional and flexible supports that help people live the lives they want, collaborations and partnerships with providers and community-based organizations, a focus on community employment as both an outcome and intervention to achieve better health, the importance of trusted long-term relationships and valued roles for all of us, including people with intellectual and developmental disabilities. This is what it takes. It takes listening to people's needs, desires, and goals, knowing it can get better and that anything is possible. This is what it takes so people can live full lives in a place they choose that include valued roles in their communities, better health, and lasting relationships. Thank you.
If yes, press 1. If no, press 2.
Got through that right part.
Thank you, and our apologies for
All
the
guests have
technical
been muted.
interruptions.
You will now rejoin the meeting.
I believe, Donna, you're next?
I think Drew is.
Oh, I could add this one wrong.
Drew, I think.
Hi, everyone. My name is Drew Smith. I'm the Director of Research and Data with the Council on Quality and Leadership, or CQL for those of us in the field. CQL is an international nonprofit primarily focusing on provider accreditation standards. I'm not going to talk about accreditation here today. We're going to talk about outcomes, and I'm going to talk to you about how we at CQL measure outcomes, what the importance of outcomes are, what we see in outcomes over the last 20 years, and the role of outcomes as you shift into this notion of managed care and what does it mean for individuals with intellectual and developmental disabilities. So again, briefly, we'll look at about 20 years of what we call the personal outcome measures data. I'll talk about what those outcomes are, what they mean, how they were selected, to really see what we see in data over time. Do outcomes shift? What do those shifts maybe mean? We'll then look at data specifically around managed care services in a study we did looking at outcomes in managed care. And then we'll look at what we call predictor outcomes. And so what outcomes, when we focus on them, help to achieve greater outcomes in individuals' lives overall. And then we'll talk about, well, why is this all important, and try to pull it all together. I will say we're going to be looking at some data. On the smaller screen, it might be challenging. For those of you who are able, you might want to look at the screen behind you. It's a little bit bigger. Otherwise, the slides will be available if you want to look at it in more detail. So at CQL, we use what we call the personal outcome measures. The personal outcome measures were developed in 1997 through a very long stakeholder process, identifying outcomes important to individuals with disabilities, their families, and really outcomes to the greater community. As we look at some of these, you'll see that these are applicable to all of our lives. They're really value-based, individualized quality of life measurements. The value here in the personal outcome measures is it is a valid and reliable assessment. And so what I mean is it has gone through statistical testing to make sure that responses that we collect, that data can be used in decision-making, because it does meet the requirements of being a valid and standardized tool. So we have 21 outcome measurements that we look at, and we'll look at those in 3 different factors of individuals' lives. Now, the important part that we're not going to be looking at today, but I'll talk about briefly, is outcomes don't just happen by themselves. There's supports in place behind those outcomes that help individuals achieve these key quality of life measures. And so what the PALM does, the personal outcome measures does, is it measures, are the outcomes present, yes or no? Are supports in place to help those outcomes be present? I won't be showing that data. If you want to see some of that data, our website has lots of it. As I said, this information is used in accreditation, person-centered planning, ISPs, organizational change, and now with the new HCBS setting requirements, pretty heavily in state reporting to Medicaid. As I said, this gets small. So this first piece that we're looking at is called myself. And so this grouping of outcomes is really looking at who am I as a result of my heredity and my choices. And so in this grouping of outcomes, what we're looking at are a few different pieces. So it's how connected am I to my family? So we're looking at natural supports. That's that first outcome over here. So we're saying that over the last 20 years, people are noticing that they're less connected to their natural supports. Now, that's not surprising. As we look at trend data for the service system as a whole, over this same time period, the number of people living in group homes has grown exponentially. And so there has been more folks moving out of a natural home setting, although now that's picking up and changing a bit. So that would be driving some of this. But really what we want to look at is in this first domain, we have the kind of individualized outcomes that we've been measuring since the service system was a service system. People are safe, people have best possible health, and people are free from abuse and neglect. If you look here, those are the 3 highest performing outcomes, and we'll see that those are the 3 highest performing outcomes across all 21 of the outcome measures. Again, not surprising. We've been doing this for a very long time. If we haven't gotten this right by this point, we're probably not going to get it right ever. But what we want to focus on, and especially as we think about individualized care and we think about shifts into managed care, where there's a lot of concern from the advocacy world around, will I get lost in the system, is pieces like individuals exercise their rights. So we have this outcome here towards the middle where it's individuals exercise their rights. Now, what we've seen over 20 years is this has grown exponentially. Individuals have gotten a stronger voice in the service system. But overall, over 20 years of data, the average is still only about 51% of individuals accessing services feel like they are exercising their rights. That means their right to voice their own opinion, the right to vote, the right to have friends, the right to connect with their community. That's troubling. The other piece that we see a decrease here is continuity and security in services. So individuals feel like the individuals who are providing them care now will be providing them care into the future. Ari talked earlier this morning around the role of staff stability. Well, in outcomes, we see a direct correlation here. We see that if you don't have staff stability, then the individuals who are accessing care don't feel like they can trust the individuals who are providing their care. They don't feel like they can trust those individuals. They don't feel like they can really tell them if there are concerns around abuse or neglect, or if they really aren't providing the services that they really care for. And so what we'll start to see is these individual outcomes really snowball across an individual's life. So the next domain is my world. So this is where do I live, where do I work, and really, where do I belong or where do I connect? We've heard a little bit about the new home and community-based services settings, really emphasizing the role of choice in service delivery, a great formal approach by CMS. What we see in the outcomes data, however, and this would be similar in the data collected by the National Core Indicators, is that less than 50% of the service population chooses where they live and with whom they live. That's a challenge. And as we think about it, as a core piece of our own existence, I choose to live with my wife and family, well, most of the time. But other people don't have that choice. They don't have the ability to make that decision for themselves. Managed care, as you're managing a network of providers and that risk transfer is happening, that becomes another risk factor there. If you're not having the choice now under a fee-for-service setting where that's supposed to be more transparent, more fluid, what will happen then under a managed care setting? Ari also talked about employment services. Here we see that on average, 40% of the service population chooses where they work. It's a challenge. I mean, where do you develop goals and where do you strive for more if you don't have choice in one of the things you spend most of your time doing? We also see that only around 40% of the population perform different social roles. Social role can be I am an active community member at my church. I volunteer. I am engaged in my community life. This means that people are probably spending a lot of time watching Oprah in a group home. They're not engaged in doing meaningful activities. As we move towards managed care, it's something that we need to be thinking about. How do we really get people involved? That's the goal here. That the whole reason of the service system is so that individuals are making decisions. The dog is wagging the tail, not the tail is wagging the dog. So it's not about how do we manage services within utilization requirements, but it's how do we support individuals to enhance their lives. So next we look at my dreams. So this is, I like to think of it as, where do I want my life to go? What's important to me? Now, one of the oddest pieces of information I find in this data is if you look at the first outcome, it is individuals choose personal goals. On average, 50% of people are choosing personal goals. The next outcome is individuals are realizing personal goals. 75% of individuals are realizing goals that they did not choose then, because you can't have more people realizing a goal if they did not choose that goal. And so again, we have to think about ISPs and what is the role of an ISP as we're thinking about goals for individuals. Is it to say, Tommy, I think that you're not going to fall so much. That's not a goal. That's not an outcome for an individual. That's an output of the system. You have adequate services and support so you don't fall. The goal is, Tommy, I want you to be more engaged in your community, and here's how I'm going to support you to do that. And he needs to also be making that goal as well. We also see that roughly 53% of individuals notice having friends. That's challenging. That's something NCI talks a lot about with their data as well. How do we connect individuals to develop those natural supports? We talk about the role of managed care, partially to reduce the reliance on the service system. One of the best ways to reduce the reliance on the service system is to have natural supports and friendship. Well, if we're not helping to promote friendship and help individuals to build meaningful and long-lasting friendship and natural supports, how can we really expect that to happen without being concerned about the risks? So this is kind of national data over 10 years. And a lot of times when I talk, people say, yes, but this won't work in managed care. And so I like a challenge, and so I set out to see if it would work in managed care. Worked with the group Cardinal Innovations Healthcare Solutions out of North Carolina. Some of you might have heard of them. They were previously Piedmont Behavioral Health.
2 minutes.
2 minutes, okay. And we really looked to do a study in managed care settings are outcomes for individuals impacted by location, service mix, and decision authority. Everyone thought, in managed care, everything's going to look horrible. It's not going to work. You're not going to be able to get this data because that's not our focus. Our focus is not an outcome-driven system. It's more of an output-driven system. The data was very telling. It's starting to make some very significant changes within the managed care model in North Carolina. What we found is individuals without a formal guardian achieved greater outcomes across the age spectrum, except those aged 51 to 64. That means individuals participating in supported or independent decision-making had greater outcomes within their lives. Individuals participating in integrated community employment have the highest average outcomes when also paired with residential type. So looking at all the day programs, individuals engaged in integrated employment had higher outcomes. Unlicensed family living arrangements had the highest outcomes present regardless of day activities. That means settings where it was more standard of a family type setting with less formalized supports had higher outcomes. So the data indicates that, as expected, individuals in more integrated community settings engaged in integrated community employment achieve greater outcomes. Kind of a dumb moment. People who have better opportunities to be engaged in their communities achieve greater outcomes even in managed care. We now have the data to show that. Quickly, I'll talk about predictor outcomes because I think this is interesting. Again, the goal is to not have the service system dictate quality of life for individuals, but to have individuals guide what services are provided to enhance quality of life. So at CQL, what we did is what we call a correlation analysis, looking at which outcomes, when present, correlate to a higher number of outcomes being present in an individual's life. And we have the top 5. Individuals exercise their rights, they're treated fairly, choose where and with whom they live, interact with members of the community, and choose where they work. Interestingly, we don't have time for this, but if you were to look back at the charts earlier, these 5 outcomes are on average the lowest performing outcomes across the service system. The reason for that is they're challenging. People really focus on, again, those historical outcomes, freedom from abuse and neglect, people are safe, people have best possible health. But what we know is that if you exercise your rights, you're more open to speaking about health concerns you have about your own body. You're more open about speaking about chances that you are being abused or neglected within your service system. You're more able to choose your services and to really make decisions about what you want to happen in your life. So as a recommendation, as you move forward, these are some outcomes to be looking at and thinking about as you move, again, to a greater step into managed care. And with that, I will pass it on.
Thank you. I hesitate to even say I think it's Donna next.
That's right.
There we go.
I pushed the green button. Does that mean you can hear me? I'm Donna McDowell, and I have lived the history of home and community care and managed care in Wisconsin for most of my adult life, which is why I've been brought out of retirement to talk to you for, I think, 5 minutes. But I'm also here because the focus here is on the really important and significant issues of managed care and people with disabilities. But it's important to remind everyone that there's a large population of older people for whom all of the principles don't exactly apply quite the same. There are nuanced differences and differences in the journey that people follow in long-term care. So I've titled my few remarks, Staying Healthy in Old Age, the Job of Integrated Care. And that's what I think we should be focused on. In any survey of old people, and I should qualify this by saying I am now an old person. I just had my 70th birthday, so I'm feeling like I can speak with the beginning of a little modicum of experience. In any survey of older people, or in any conversation with a grandparent for that matter, the most important aspiration of people in advancing years is stay healthy. That older people so routinely respond this way reveals a common underlying anxiety about the future. I don't want to lose my physical independence as a result of a costly health crisis that is likely to leave me with permanent disabilities and chronic health problems. But also, I don't want to lose my financial independence as a consequence of the costs of health care and long-term care, which do pauperize older people, whether low income or middle class. And then the usually unspoken anxiety, I don't want to talk about or think about the risk of Alzheimer's disease or other dementia, despite the fact that 1 in 3 people will display dementia if they live to their 80s. In my 40 years of doing public policy here, in other states, in Australia, in the UK, the aspirations of older people haven't changed, but public and private responses have improved, along with knowledge and understanding about aging. Obviously, there isn't time today to summarize the issues, the errors, the costs, the politics, and the compassion that shape our responses to old age. Whether home and community care, Medicaid managed care, integrated care, or the next best mechanism for financing and delivering care. Healthcare for older people usually involves managing several chronic conditions with several, many prescription medications, some of them the right ones, and individual plans for prevention and health promotion, including nutrition and exercise. The Wisconsin Aging Network and the Aging and Disability Resource Centers have increased their capacity to provide these health promotion, health maintenance programs aimed at preventing falls, avoiding malnutrition, managing complicated drug protocols in coordination with local health providers. For elders with limited mobility, a vast network of volunteer drivers and local transport older people to doctors and clinics and rehab appointments. At least they used to before we launched into a new brokerage system that doesn't work. The Institute for Healthy Aging here in Wisconsin provides training, research, and technical assistance to make these prevention programs work right. Keep in mind that all older people rely on Medicare, not Medicaid, Medicare, to pay for primary as well as acute care. People purchase supplemental Medigap policies to pay for the 20% of the bills that Medicare doesn't cover, or they may be enrolled in managed care plans and pay premiums to cover the gap that Medicare doesn't. There are annual enrollments for these plans. Poor elderly people rely on Medicaid for the supplemental coverage. And it's important to remember that these older folks are generally people of color with a higher incidence of chronic health problems as well as higher rates of dementia. And we cannot overlook that reality. For the majority of elders not already on Medicaid, drug coverage comes from the so-called Medicare Part D plans purchased by elders, or their privately purchased managed care programs may also cover drugs. They have to enroll annually and verify that the drugs they take will be covered. Older people make choices about their health insurance and providers, often guided by their loyalty and attachment to particular physicians or clinics. In rural areas, choices are more limited and geographic proximity becomes paramount. Access to veterans' health services adds another dimension to the choices and arrangements elders consider. Wisconsin has a unique and high-quality benefits counseling system to help choose, enroll in, and insure benefits for elders and more recently for people with disabilities, with the backup and support of public benefits attorneys to redress grievances. But of this whole list of what we have going, family, that is spouses and adult children, and voluntary caregivers provide a majority of the care and services elders require today. It isn't realistic to design a system or a program that assumes that older people will need and choose that plan at that particular point in time. For the majority of elders, they enter Medicare healthcare systems at the age of, say, 66, and they either gradually or cataclysmically acquire disabilities and chronic health problems. Their needs increase for assistance with everyday activities incrementally, activities like bathing, toileting, or eating, what is known as long-term care. Long-term care has evolved as a social model of care, blending voluntary, paraprofessional, and professional social and health services aimed at supporting the elder in the lifestyle that preserves and promotes independence and maintains at least familiarity. Most elders pay out of pocket for many services and supports. Few have an income that will purchase the help they need to live in the home that they've chosen. And so they begin to deplete their savings. I know we're not talking about it here, but the manner in which the system continues after all these years to pauperize old people is an ongoing shame, and we shouldn't be ignoring it. Ideally, a new version of integrated care that assumes responsibility for prevention, primary, acute, and long-term care for elders that are Medicaid eligible is built on existing systems of care that are reasonably respectful of choices already made by elders about doctors, drug plans, clinics, hospitals, living environments, social connections, and the day-to-day routines that have been shaped by lives well lived. If elders are expected to enroll in something new, like an IHA, let it be a familiar and trusted social and healthcare provider. Rural counties in Wisconsin have a majority of elderly citizens, and that aging majority will grow. Will there be an adequate supply of providers, much less an adequate supply of choices? Most importantly, let it be a stable provider that will not pull up stakes and leave when it is evident that this work really is not profitable. This is not imaginary. This is what Advantage plans did in the state 10 years ago. And while Medicare Advantage plans now cover as many as 30% of elderly, there are fewer and fewer companies offering Advantage plans. They're merging and merging. So there's too little competition to actually achieve savings in a marketplace.
1 minute.
How much?
1.
No, it's going to be 3. If there's meant to be choice, let's have benefits and legal specialists continue to be available, as they have been for the last 3 decades. How many annual enrollments will an elder have to figure out? A strong care management model that is person-centered is the only demonstrated way to know the elder well enough to support the aspects of daily life that matter the most. That means effective and respectful collaboration between social and medical care sectors grounded in the community. Conflict-free case management is the latest jargon for saying we want to prevent the care manager from recommending only the service providers and housing that belongs to her employer. And supplement, don't supplant, the fragile lifestyle of an elder and its network of informal caregivers and minders. But inevitably, if an older person lives long enough, whether it is discussed and planned for or everyone is just keeping their fingers crossed like I am, Alzheimer's or other dementia will inevitably be the dominant force in her life. There are many good strategies for the management of dementia that have emerged in the Department of Health Services Dementia Care Redesign, and they will be revisited in Speaker Voss's task force on Alzheimer's. A new Medicaid model of integrated healthcare must incorporate the objectives and strategies of these 2 dementia system developments that hold both promise and peril for 1/3 to 1/2 of the elderly users of long-term care. So the message I'm trying to make clear is that there are all these components of a system. As we build, we have to build on what we have had. And we cannot drop a new system from 20,000 feet and expect that it would not crush everything that was already there. But in conclusion, I want to say the centerpiece of yet another system redesign. We've been through so many, but you know what? They always get better. It must be the command and control center. Edna is 85 years old and lives in the first home she truly considers her own, a subsidized apartment in a senior high-rise. Edna organized a command and control center with her favorite chair centered in front of the television with clear pathways for a walker to navigate to the bathroom and kitchen. A metal TV table in a 60s motif of avocado green and burnt orange holds her telephone, a landline, a small electric tea kettle, a mug, a pencil, and a folded crossword puzzle from the newspaper, a weekly display of her medications and eye drops, a Harlequin romance, a remote control, and a lifeline or one of those fancy new iPads that keeps her somehow connected with her care manager. A homemade Afghan is draped on the arm of the chair. The front door is closed but unlocked until a familiar voice says, Hello, lunch is here. Baked fish, corn, and applesauce today. Leave it on the counter by the fridge. Thank you, dear, says Edna, knowing that this meal will go in the freezer. This fishy meal will go in the freezer to be saved as a gift for her niece when she comes to help on Saturday. She looks in her date book of birthdays, pulls out a card to address to her great-granddaughter with a crisp dollar bill inside. Her neighbor across the hall will pick up the card to help her clean up, will pick up the card to mail when she brings her mail in the morning. Edna will wait until the girl arrives to help her clean up and dress for bed. Maybe she'll have time to phone a grandchild. She clicks off the TV. As she rests her eyes for a moment, she hears an ambulance down the street. One of these days, the ambulance will come for her. But not yet, Lord. She has her life under control, and she is content, no longer obliged to live in other people's homes and clean and do their laundry. As long as she has her own apartment, her Social Security, her Medicare, and 7 prescriptions, Dr. Chowdhury, who understands her, and a few good souls regularly checking in and helping her out, she'll make it another few years, God willing. Think about how our new managed care system will keep older people in their command and control centers. Thank you.
Thank you. From the evil timekeeper.
I'm sorry, that's right.
I believe
People who
Councilor...
know me will know you just don't tell me to stop.
I think Councilor Neiman does have a question, however.
So my question is directed in follow-up in particular to the CQL presentation, but all of the panelists should feel free to answer it. So I was particularly struck by the degree to which, both in the CQL data and in the comments of our first panelist, was it Sue? Thank you. Employment had such a disproportionate effect on outcomes for non-elderly people with disabilities. And I'm wondering if you can talk a little bit more about why that is, and then in particular to the CQL representative, I know that in some of the other data tracking systems, and I'm thinking particularly of NCI here, they've been able to disaggregate some of those quality outcomes based on level of intellectual disability to show that these things hold true at every single level of impairment. And I'm curious if CQL has been able to do that. So if we could hear first from the CQL representative, and then Sue, if you'd like to add from your experiences as well, I would find that very helpful.
Sure. So thanks, Ari. Let me talk first about your second question around disaggregation, because it's fresh on my mind. Yes. So the benefit of the CQL data is currently we are the only outcomes data that collects at the individual level that we can actually individualize, track an individual for their services through the provider, through the state. So we can look at that data across a whole lot of demographic spectrums. January of this year, we just released a new version of the personal outcome measures that puts in a lot of demographic data specifically tied to the new HCBS setting requirements. We've also linked the data using the same definitions used by the University of Minnesota for residential service options and the same employment and day service definitions coming from the University of Massachusetts Institute on Community Inclusion. The reason for that being to really look at what you're talking about of standardizing some sort of analysis, but really being able to disaggregate this and look at some consistency across the system so that we're comparing apples to apples. In that demographics, of course, we do have type of disability, level of disability, looking specifically, however, at individuals with complex medical, complex behavioral support needs. And using the definitions coming from AAIDD around the supports intensity scale. Again, trying to build some relationship between this data and everything else that's happening, so we're not working within a silo anymore. I think our system has worked in data silos long enough. To the piece around employment, I won't speak at great lengths around elderly. I will say that although we do accredit some agencies providing elderly services, about 95% of our data is around the IDD community. This has been a challenge that John Butterworth has been working on since we've been collecting personal outcome measures data of what's happening in employment services. Not talking CQL data directly, I'll talk about a past role I had at another employer. I conducted an audit of the Washington State Developmental Disability Service System. If those who follow employment services for the IDD community know that Washington State is what is touted the gold standard in employment services. And as we started to dig into the system, what we found is, yes, 90% of people had employment services. However, there's a very important policy in Washington State that a lot of people don't talk about. It's not published in the data. In Washington State, for the first 3 months of service, when you come into the system, you must try employment services. Now, that sounds great. I mean, it really focuses you to do job development and try to get a job. But what advocates continue to tell us is I was being forced to fail at employment to be able to choose other services. And so we went to Linda Rolfe, who was the director of DD Services for Washington State, and we said, Linda, you're paying a lot of money. You have some advocates who are pushing back on you. It seems like infrastructure is not being developed quickly enough within your private sector to provide jobs. And Linda said simply enough, we made a decision we were going to pay for this. We believe in it. We know that it's not going to be quick, but we believe in it. And we're willing to put the money there to help develop that system. That's what it takes. It takes the development of the infrastructure to really build the system and to change perceptions around what it is individuals with intellectual and developmental disabilities can and cannot do in the work environment. And what we see from this data is it hasn't caught up. I mean, we are looking at the state, all of the states, not just Washington. And so what we're seeing is that people aren't choosing those because there hasn't been the commitment nationally to employment services.
Okay, we have time for one more question to our panel. Do we have any? No question?
Yes, one question.
Could you
Go ahead.
Come up to the microphone, please?
Thank you. I just wanted to follow up with the first speaker who had talked about integrated care model, and I wasn't clear what that model was. Is that in Wisconsin, and if so, what program was she sharing as a model to hold up for future success? Thank you.
Sure. Where this was back, I worked for Dane County, so this was exclusively in Dane County model, and they had the foresight to understand what it would take to support people and cost effectiveness back. This is late 90s, early 2000. And my job was funded by the county and through residential support services. And it was pretty exclusive to Dane County. And they've continued with that model. Now their nurse case managers are through the Weissman Center, but that continues. And you can see the success through there. I believe you have 19 supported residential support service agencies in that county. So I was fortunate enough to be part of that. Mm-hmm.
Okay, we're going to take a short break, and then we will reconvene. We need to give our CART reporter her fingers a little rest. So how much time, Ellen?
We will start back at 1:45 promptly.
Quarter of. So, again, thank you to our panelists, and thank you for your attendance.